Hi guys, welcome back. We shall be talking about COPD and I'll be first explaining to you manifestations with respect to emphysema, which is an example of type 1 failure, and respiratory alkalosis. Now I'll try to explain to you why did I say type 1 failure and why did I say respiratory alkalosis, which are the endpoints for MCQ in this particular topic. You can take this to be representation of the terminal bronchiole, then is the respiratory bronchioles, and then is the alveoli, which have been shown here, which are the basic units of gas exchange. I'm describing a heavy smoker. When tar will go into the lungs of the patient, this tar will cause irritation of the macrophages or the security system which is present in the terminal airways, and these macrophages will be irritated to produce an enzyme by the name of elastase, and this elastase will then start causing digestion of elastin, or it will cause damage to elastin which is present in the connective tissue. You see, maximum damage is seen in this particular area, that is the respiratory bronchiole. If this area that I mentioned before you is respiratory bronchiole, this is the area that sustains the maximum damage. When a person smokes on a cigarette smoke rises, so upper lobe is mainly involved, and at the same time I can also say the fact that respiratory bronchioles are the one which bear the brunt of the disease. This respiratory bronchiole wall is damaged, and the elastase enzyme which is produced here will contribute to digestion of the elastin component in the wall of the respiratory bronchiole. So if you look at the airways of this patient, something like 20 years from today, the terminal bronchiole will look the same, but look at the respiratory bronchiole. I have shown it in the form of these big blebs. These are the alveoli of the patient which have been shown. And you can also see that in these patients I have shown these blood vessels which are surrounding the alveoli. As you can see in the representation, I have deliberately modified the diagram to say that when air will go inside, a lot of this air will be trapped in these blebs that I have represented before you, and because of the trapping of the air in the blebs of the patient, you would be having relatively less delivery into the alveoli, and since you are having less delivery into the alveoli, there is hypoxia, and this hypoxia will explain the fact that in these patients there will also be vasoconstriction of the pulmonary bed, since I have emphasized multiple times earlier that hypoxia causes blood vessels of the pulmonary vasculature to constrict. So deliberately shown these blood vessels to be of unequal caliber as compared to the original diagram where I deliberately drew these blood vessels to be of equal caliber. So this patient is having two problems now. He's having a ventilation problem and a perfusion defect. The hypoxia in this patient will also cause this patient to hyperventilate, and because of the hyperventilation that will be developing in the patient, there will be a development of washout of carbon dioxide from the body. So you can see that both oxygen and carbon dioxide will become lesser in the body of the patient. That will explain why these patients are having type 1 respiratory failure, and less carbon dioxide means less protons, so respiratory alkalosis. So the first message that I want you to carry home from this particular representation is that emphysema is characterized by development of blebs in the airways. This disease is an example of type 1 respiratory failure because there is a hyperventilation ensuing in the patient. These patients, due to wash off of carbon dioxide, will be having less proton generation, so having respiratory alkalosis. In these patients, you can see there is trapping of air in the lungs. So I'm going to do this activity again. Keep your eyes on the board so that you can follow my sequence. Instead of asking this guy to inhale, I'll be requesting this patient of mine to exhale out. So see what happens, and I'll use a different ink to highlight it. When I ask him to exhale, air will go out like this as I did initially. The air will go out, but then at the same time you will notice that lot of air will get trapped in these blebs. If the air will once again be trapped in the blebs of the patient, you can see amount of air going out of the blebs of the patient will be, the amount of air going out of the airways of the patient will be relatively lesser. So in these patients, FEV1 will always be less than normal. Now I will give 2 puffs of salbutamol to the patient, and I will ask the patient to wait outside the spirometry room. After 15 minutes, when I will check the FEV1 of the patient again, I will notice the fact that the FEV1 of the patient will remain the same. It will not change, unlike in asthma where there is a relief of bronchospasm. Therefore, emphysema is an example of non-reversible airflow obstruction. Whereas when it comes to bronchial asthma, as you can see, this condition is not having any change of FEV1. So this is an example of non-reversible airflow obstruction. Bronchial asthma is a reversible airway disorder, but in this medical disorder, you are having a non-reversible airflow obstruction present in a patient. So the main aspects to be remembered are type 1 failure, respiratory alkalosis, and non-reversible airflow obstruction. If they ask you what is the investigational choice for emphysema, do not answer spirometry because it requires cooperation on the part of the patient. The investigational choice for emphysema is HRCT, high resolution CT scan, where you will be able to notice blebs or large bulla that would be present in this patient. If they ask you regarding what is the most common complication that is encountered in patients of emphysema, then these patients will be having a development of pulmonary artery hypertension due to constriction of the pulmonary bed, and that will put stress on the right ventricle and that will cause right ventricular failure. So the most common complication is cor pulmonale. But if the question begins by saying that this patient has suddenly turned blue, like this patient was sitting comfortably watching television and he was puffing on a cigarette and he suddenly turned blue, then in those circumstances, when you read about emphysema patient, known case of emphysema suddenly turned blue, it means that there was a rupture of a bulla and this patient has developed a complication by the name of spontaneous pneumothorax. Spontaneous pneumothorax will be characterized by absent air entry and absent breath sounds, and we will have to treat the patient by needle aspiration or by putting in a chest tube. The pneumothorax component is dealt separately, so you can listen to the pneumothorax component for it. But I want to highlight the fact that overall the most common complication of the disease is cor pulmonale, and if it describes a sudden presentation, it is spontaneous pneumothorax present in the patient. The sketch of mine represents the fact that why do these patients are having a non-reversible airflow obstruction. Air trapping is a hallmark feature of emphysema, which also explains the fact why in physiology they teach us that residual volume is increased in the patient. That increased residual volume is secondary to air trapping occurring in the blebs of the patient or bulla of the patient. Therefore, total lung capacity of these patients will be more than 6 liters. We will compare emphysema with chronic bronchitis now. You see, our airways tend to have pseudostratified ciliated columnar epithelium. So I have here shown cilia. All these cilia beat in a single direction. So like an escalator moves in a single direction, cilia beat in a single direction. We are going to call it a mucociliary escalator. This is the tracheobronchial secretions. In blue, I have shown the tracheobronchial secretions. This is the mucus, this is the tracheobronchial secretions, and they are in constant state of motion. So our tracheobronchial secretions are continuously moving because the cilia are like a cleaning mechanism and they keep the lungs clean. If a person is a heavy smoker, the tar that will go inside the lungs will be causing damage to the cilia. And because of the damage to the cilia, the mucociliary escalator will fail and there will be stasis of secretions in the lungs of the patient. Because of stasis of secretions in the lungs of the patient, there will be development of infection, and infection obviously will translate into pus. So we are now discussing regarding another domain of COPD, that is chronic bronchitis. This is a disease that is characterized by development of pus in the airways of the patient, and therefore if I represent this as the terminal bronchiole, this is the respiratory bronchiole, this is the alveoli of the patient, these are the blood vessels that are surrounding it, then what I'm saying is that in these patients I have now shown presence of pus sticking in the inside of the terminal bronchiole. I've shown pus which is causing occlusion of the respiratory bronchiole of the patient. So the implication of this will be that when air will go inside, one, there will be turbulence because airway is relatively narrowed because there are secretions present. Second, there would be air going into one of the alveoli, but the other alveoli is underventilated. So in the underventilated alveoli, I will modify the diagram now by saying in the underventilated alveoli, because there is very severe deficit of oxygen, the blood vessels which are present here will exhibit vasoconstriction. In patients who are having presence of chronic bronchitis, there is severe underventilation of some of the alveoli, so there is a very severe hypoxia, which will explain the fact that why these patients are having a central cyanosis. Now if you focus on this particular part of the alveoli which is underventilated, from this side even carbon dioxide cannot come out. Other side carbon dioxide come out, but on this side you can see, because the blood vessels are constricted, gas exchange is impaired, the carbon dioxide cannot be excreted. So in the blood the levels of carbon dioxide will gradually start increasing. The reason why I am highlighting in this case that carbon dioxide will increase in the body is because it will not get an access to outside, because the blood vessels are constricted, so gas exchange is impaired. So carbon dioxide will accumulate in the blood, and increased carbon dioxide always causes narcosis. So this particular person will be having very limitation of activity and will keep on sleeping most of the time. If a person will keep on sleeping most of the time, therefore in this person you will notice that there will be a weight gain. So most of the time these patients are having central cyanosis, so we call them blue, and they tend to become relatively fat, so we call them blue bloaters, whereas emphysema is called as pink puffer. Since there is no cyanosis, it keeps on puffing on a cigarette all the time. So blue bloater is just a relative term to highlight the severity of hypoxia. The hypoxia severity is so bad here that these patients will be wheelchair bound. These patients will be coming to you on a stretcher. They won't walk into your casualty, but these would be sick patients, and they will also have narcosis. They will keep on sleeping most part of the day, so they tend to put on weight also. This is an example of type 2 respiratory failure. Since there is buildup of carbon dioxide in the body, the buildup of carbon dioxide will also contribute to generation of protons. So therefore this condition will be having respiratory acidosis. So the main reason why I've gone into this topic is to explain to you that why do you read about type 1 failure in emphysema and why do you read about type 2 in chronic bronchitis. This is underventilated alveoli which will result in buildup of carbon dioxide in the body, and the protons generation will explain the respiratory acidosis component. These patients will also be having symptom of bronchuria, whereas I never spoke about bronchuria with respect to emphysema patients. Once you've understood the difference between the two perspectives of COPD, I'll just highlight why these patients come to us. When it comes to emphysema, the question will always begin by saying a tall, thin smoker. And this tall, thin smoker will always be having a complaint of exercise intolerance. Like he says, doctor, earlier I could climb the stairs of my house 10 times per day, but now even once makes me feel tired, and there's breathlessness in this patient. This tall, thin smoker with exercise intolerance, when you examine him, you will notice that his respiratory rate will be faster than yours and mine. You will notice that his accessory muscles of respiration will be working overtime, like sternocleidomastoid, though he, let me say, climbed 1 flight of stairs to come to your clinic, but he's breathing as if he's run a half marathon. So accessory muscles of respiration would be working overtime in this fellow. And when you will ask this guy to take off his shirt or t-shirt, you will notice that the person will be having a barrel-shaped chest. Now, barrel-shaped chest implies the fact that the anterior-posterior diameter of the chest will be more than the transverse diameter. In you and me, shoulder to shoulder, transverse diameter is more than the AP, but in this guy, it is AP diameter that will be relatively more than the transverse diameter of the chest. In these patients, you will notice that there is hyperinflated lungs. Because the lungs are hyperinflated, remember I told you air trapping. So because of the hyperinflation of the lungs of these patients, you will notice the fact that the dome of the diaphragm will be pushed down, and that will push down the liver, and therefore the liver of this patient will become palpable. I did not say hepatomegaly. I simply said liver will become palpable. The liver is usually palpable in emphysema patients because of the air trapping which is present, or hyperinflation. Hyperinflation will push down the dome of the diaphragm, and therefore the liver becomes palpable in these patients. When you will be doing a workup of these patients, the first test that you will advise for this person will be spirometry. And you will notice that the FEV1 of the patient is definitely not going to change. So this is an example of a non-reversible airflow obstruction. However, in most of the MCQs, they will either ask you about HRCT finding of the patient, which is the IOC for all parenchymal disorders, that is presence of blebs and bullas can be seen, or they will ask you regarding ABG finding of the patient, which you will answer as presence of type 1 failure. The explanation has already been provided, along with presence of respiratory alkalosis. Or in some questions they can mention regarding a rare test which is usually not done in clinical practice, but still they can mention about DLCO. Now DLCO simply stands for diffusion capacity of the lung for carbon monoxide. In a normal person, the diffusion capacity of lung for carbon monoxide versus this guy, all I'm saying is there is trapping of carbon monoxide in the blebs. If there is trapping of carbon monoxide in the blebs, the carbon monoxide that will reach the alveoli will be lesser, and if carbon monoxide reaching the alveoli will be lesser, then DLCO will be also lesser. You see, whether it is carbon monoxide, whether it is oxygen, whether it is any gas per se, all gases are going to reach the alveoli lesser in the patient, simply because if you look at this sketch that I made before you, the air will be wasted in the blebs because there is air trapping. So ultimately delivery into the alveoli is compromised. And that explains the fact that why DLCO in these patients is said to be lesser, though this is a rare point. MCQ wise this is important. For these particular patients, if you are going to do a chest x-ray, the chest x-ray in a patient of emphysema will be very characteristic. Unlike a normal person's x-ray, you will notice that in this person the dome of the diaphragm of the patient will be pushed down. There would be flattening of the diaphragm. Normally, whenever I draw an X-ray before you, I always try to show a curvature. I try to show cardiac borders like aortic knuckle. I try to represent the apex of the heart. But in this condition, what I've done deliberately is that instead of showing the curvature of the diaphragm, I have tried to show that there is air trapping. So because of the air trapping, the lungs will look relatively much more black. You will also notice that this patient will be having flattening of the diaphragms. You will also notice that the patient will be having a tubular heart. Whenever you see in a chest x-ray in the paper a tubular heart, it is always suggestive of emphysema. The lungs will be more black than normal. But at the same time, vascular markings can still be made out. Because I have explained to you that if the lung is jet black and vascular markings cannot be made out, it is pneumothorax. But here the lungs will be more black, vascular markings will be there. So if you see these following findings, you should not be able to think in terms of pneumothorax. I mean, you should not misdiagnose this as pneumothorax, because most people tend to, look at an X-ray and think this is bilateral pneumothorax in a patient. In pneumothorax, you are always able to evaluate presence of absent vascular markings. Deep sulcus sign that I highlighted in the earlier part of the discussion. But this person will be having a tubular heart, a flattened diaphragm, lungs which are more black than normal because of air trapping with vascular markings. Once you identified this condition on the basis of combination of these findings and clinical symptoms, it is time for treatment of these patients. So we will obviously advise this person to quit smoking. For quitting smoking, we can advise this guy to use a nicotine buccal spray, which is overall the best method to help a person quit the habit of cigarette smoking. So if they ask you regarding what is the DOC for nicotine addiction, then the drug of choice for nicotine addiction should be answered as nicotine buccal spray. Another thing that they've asked is varenicline. Varenicline is also useful for those patients. I mean, nicotine buccal spray is to be used in that person who can understand that when he's taking a buccal spray, he's not supposed to smoke on a cigarette. A lot of people will use a buccal spray, then will smoke on cigarette also, and that means that more nicotine is going in the body. So it will be party time for him. He will say, I get double the kick. So the funny part is nicotine buccal spray is required should be prescribed to those people who can understand that when I'm using a buccal spray, I'm not supposed to smoke on a cigarette. And some people with relatively less IQ, less education level might be using buccal spray plus smoking on a cigarette, and that means more nicotine is going in the body, so it's party for him. So suppose a patient is having a less IQ and is not understanding what I'm saying, then I will advise him varenicline. This is a drug, the backup drug for nicotine addiction, which is the alpha-4 beta-2 partial agonist of the nicotine receptor. You can understand that if I am going to block this receptor, partial agonist can also block. If I'm going to block the effect of nicotine on the brain, this is a receptor of nicotine in the brain. So if I block the effect of nicotine in the brain of the patient, the pleasure, the kick that comes out of cigarette smoking will definitely be compromised, and therefore patient might give up the habit of cigarette smoking. Obviously counseling is required. For these patients, as such, there's no drug that's going to cure the patient. And I'm also going to tell this patient, because he might be having these large bullahs, so we might be going in for VATS, that is video assisted thoracoscopic surgery. And with help of a VATS, that is a video assisted thoracoscopic surgery in the patient, we will be doing a procedure by the name of bullectomy to get rid of this bullah which can rupture anytime. However, in a question, if he says what is the treatment of choice for this condition, then the treatment of choice for this particular condition should be answered as lung transplantation, and obviously that will require a brain dead donor. So most of the time patients might die waiting for a lung transplantation. Now, if you compare this information with that of chronic bronchitis question will rather begin by saying a relatively fat or a obese smoker. He might not have been fat initially, but he became fat over the last couple of years. This fat and obese smoker is having severe dyspnea to the level that he would be having dyspnea on minimal activity, like even going to the bathroom or changing a pair of clothes. So these patients will be having usually dyspnea grade 3. He would be having like dyspnea or even minimal activity, like going to the bathroom would be making him feel breathless. In that fat obese smoker, when you examine him, obviously you will see evidence of respiratory distress in the form of respiratory rate being higher. You will notice accessory muscles of respiration working overtime in the patient. You might notice the fact that this person is having use of there might be presence of subcostal recessions in the patients. That is because the diaphragm is working more than normal to deliver more oxygen into the body. So subcostal recessions might be noticed by you. You will notice that the person will be sitting with pursed lips. He will be trying to breathe or push air into his airways, and there will be evidence of central cyanosis in the patient. The lips and the fingertips will be relatively blue in the patient. In this blue bloater, you will also be having complaints of bronchuria. Pus in the sputum will be present in the patient. So bad breath can be described in the question. Why I mentioned it subsequently is to mainly highlight the fact that the severity of respiratory distress in these patients is much more than that of emphysema. And when you notice the halitosis and the bronchuria component in a patient, you have to notice the fact whether in the MCQ clubbing part is given or not, because if he mentions clubbing in a question, then it will turn into probably a diagnosis of bronchiectasis also, because clubbing is a feature of bronchiectasis but is not noticed in chronic bronchitis. You will also notice that hemoptysis will be given in bronchiectasis, that is a large airway disease, but here hemoptysis will be absent. So you have to take care of the fact that if the question starts mentioning bronchuria, is he talking about presence of clubbing, presence of hemoptysis? Because if these 2 points that are marked before you is yes, clubbing is present, hemoptysis is present with bronchuria, it is bronchiectasis, large airway disease, but we do not have hemoptysis and clubbing in these patients. Another point that will help you in differentiating would be rhonchi will be present in this particular patient, and these will be mainly inspiratory rhonchi as well as expiratory rhonchi. Asthma is a disease of expiration, so you get expiratory rhonchi, but here because I had shown pus in the airways, that is going to narrow down the airways of the patient, so you will be having a combination of inspiratory and expiratory rhonchi in a patient. Before I go forward, I want to highlight the fact that if you read a question that begins with bronchuria, even if he says a smoker and then he says that this person is having clubbing, this person is having even occasional blood in the sputum, that is hemoptysis because the pus could be eroding the blood vessels, and the patient is having presence of basal crypts. Now these basal crypts are also mentioned to be more on the left as compared to right. Then this information that I have marked out in the box before you is to be thought by you in terms of bronchiectasis. Obviously the solution will be provided by a HRCT, but bronchiectasis is a large airway disease where you have pus usually present on the left side, lower lobe because of gravity, whereas in chronic bronchitis you will read about rhonchi. So do take care of the language of the question, that will change the entire perspective or the domain. In the workup of these patients, you will notice that you will be doing a spirometry. Though getting cooperation of a sick patient is a little difficult, and even in these patients FEV1 will be lesser than normal. The second test that you will do in this patient will be a chest x-ray, because in this patient there is infection present, so there will be increased bronchovascular markings, and because of the increased bronchovascular markings in these patients, which is sometimes referred as dirty lungs to imply low-grade infection that could be present in a patient. So these are patients susceptible to development of even suppurative lung disease. They are at risk for development of pneumonias. They are at risk for development of complications like lung abscess also. In these patients, when you will be evaluating the patient by HRCT, the diagnosis will be made because you will be able to identify the presence of secretions in the smaller airways. There would be collapse of some lung segments also. So HRCT is the investigational choice for this condition. if you do a arterial blood gas analysis of this patient ABG, it will reveal type 2 respiratory failure. I've already explained that in the earlier section, that these patients will be having collapse of alveoli or underventilated alveoli, so buildup of carbon dioxide will be seen. So type 2 respiratory failure in combination with, because carbon dioxide when it is more will generate proton, so it will also cause respiratory acidosis will be present in the patient. For management of these patients, I will have to use antibiotics. There is no role of antibiotics in emphysema, but in chronic bronchitis, because we are dealing with pus, there would be antibiotics, and I will also have to use mucolytics in these patients. Antibiotics have horrible penetration into pus, that is why I am talking about antibiotics. Bronchodilators like ipratropium bromide. Ipratropium bromide is an anticholinergic molecule which can be given in form of a puffer to this patient, and that will help in better air entry. Apart from ipratropium bromide, I can use theophylline or other derivatives for management of this patient so as to achieve bronchodilation and relatively better air entry. Though there is no technical bronchospasm in the patient, still I want to dilate the airways for better entry. But in the question he will say, what is the mainstay of treatment for these patients? Then the mainstay of treatment is not to be answered as bronchodilator, antibiotic, mucolytic. The mainstay of treatment is that I will have to give this person a low flow oxygen. So I will be telling this chap that I want you to purchase a portable oxygen cylinder. He will have to take, with the help of a portable oxygen cylinder, this person will be taking low flow oxygen with the help of a nasal cannula. This is a transparent nasal cannula which he can put, and he will be taking oxygen at a rate of something like 1 liter per minute for something like 16 hours per day. I am not giving for 24 to 24 hours per day because it's not practically possible. It can also cause injury to the nasal mucosa because oxygen is dry, so it can contribute to development of damage to the nasal mucosa. But something like 16 hours per day is a justified event. And why am I doing this? I mean, why am I making him life miserable by saying purchase a cylinder, put in a nasal cannula? Is because I want to enhance the amount of dissolved oxygen in the body of the patient, and if I increase the amount of dissolved oxygen in the blood of the patient, then increasing the amount of dissolved oxygen in the blood will enhance the work capacity of the patient, and if I enhance the work capacity of the patient, it will ensure that this person is able to do basic tasks like at least change his own clothes. He can do tasks like at least going to the bathroom by himself, which these patients are severely compromised. So the mainstay of treatment should be answered as low flow oxygen. Mainstay of treatment for this patient is low flow oxygen, and is to be answered in the MCQ is the first point, right? And then is bronchodilator, then is antibiotics, and then are mucolytics for these patients. Even these patients will be having cor pulmonale, but they will not be having rupture. They will not be having rupture of the airways, unlike or pneumothorax, unlike emphysema patients. For the severity of COPD, we have what is known as GOLD classification. So in GOLD classification, we will classify COPD as mild, moderate, severe, and very severe. Because they've asked about the GOLD classification for COPD in the last time's NEET exam, so that's why this is important, that you need to understand when do you call it mild, when do you call it moderate, and when do you call it severe and very severe. So for mild COPD, the first prerequisite is that FEV1 divided by FVC should be less than 0.7. You see, FEV1 FVC ratio less than 0.7 is always diagnostic of obstructive airway disease. Mark my words, if FEV1 FVC ratio is normal or increased than normal, then it is suggestive. If it is normal, it can be normal also, but if it is increased than normal, it could be restrictive lung disease. But in obstructive lung disease, FEV1 FVC ratio is less than 0.5, 0.7, and FEV1 predicted should be more than 80% of the predicted value, then we call it mild. For the moderate one, this will remain the same, FEV1 FVC less than 0.7, because that is diagnostic of obstructive airway disease, and the FEV1 of the patient will be between 50 to 80% of the predicted value. For the severe variety, which was the one that was asked in the paper, FEV1 FVC ratio will be less than 0.7, but now the FEV1 will downgrade to something between 30 to 50% of normal. Whereas whenever you use the word very severe, this value will remain the same because this is obstructive airway disease, but the ratio, that is FEV1 value, will be less than 30% of the predicted value. Now, why am I making life difficult for you by making you cram up this data for the COPD aspect is because of the fact, or why there are errors is because when you grade bronchial asthma, in bronchial asthma, when we do grading as mild, moderate and severe form of asthma, you will notice the fact for mild, moderate and severe variety, if FEV1 is between 50 to 80%, we call it mild. If it is FEV1 between 30 to 50% of the predicted, we call it moderate, and severe is defined as value less than 30%. So what we are calling a status asthmaticus or severe acute asthma is value less than 30%. But now look at the superior information. The severe for COPD is FEV1 between 30 to 50%. That is the reason for error. Remember, in COPD, very severe is less than 30%. Very severe is less than 30%. Whereas in COPD, severe is gonna be 30 to 50%, and for asthma, severe is less than 30% FEV1 values. So it's juggling between the numbers. So I would suggest you to write it at least once so that you get a hang of it, because it looks very straightforward at the moment, but in pressure situation, most people, when they got the question of severe COPD in the paper, they answered as less than 30%, whereas actually the correct answer is 30 to 50%. So severity of COPD, that is gold classification, is the one that is to be remembered.